So breast cancer is a disease whereby uncontrolled. It's a very common cancer, and it's affecting almost all the countries. I could say that breast cancer is ranking the commonest, but the second for both, for male and female. And
sorry, doctor, we are not able to get you again. I don't know whether it's only on my side.
Can you hear me? Can you hear me now?
Yes, now I can now, yes.
Okay, now when I squeeze this, you can't hear me well, so probably I can switch off my video for now, if it's okay with everyone. So it's a very common disease, and it affects women at any age after puberty, but the risk becomes much higher with increasing age. And then it normally spreads through the bloodstream, but also through the lymphatic system. But when it spreads, we normally call it metastasis. And that being the case, when we look at the risk factors for breast cancer, we normally have modifiable and non-modifiable risk. So being a female by itself is one of the. We know male also are being affected by breast cancer, but approximately 0.5 to 1% of breast cancer, 99% of the breast cancer. So the risk increases with age, about 40 years of age. For women, they're really at risk, and also other modifiable risk factors are obesity, use of alcohol, and also tobacco and cigarette smoking, but also radiation exposure. But other non-modifiable risk factors includes family history. So women or men who have got family history of breast cancer, they also has risk. And also we have the reproductive history, whereby early age, the menstrual period is one of the risk factors, and also late menopause. But we're not supposed to be very much worried, because approximately 50% of women who develop actually breast cancer, they don't even have a family history. So majority are women, yes, about 40, but they might not have any history in their family on breast cancer. So that means we are all, being a woman by itself, you're at risk of getting breast cancer. But on the other hand, we also have a risk when genetic mutation is concerned. And a most predominant mutation is BRCA1, BRCA2, as well as PAB2, which currently have been seen to be strongly associated with breast cancer. So I really wanted us today, when we create awareness when breast cancer control is concerned, to look at the need of doing screening, apart from doing screening for early diagnosis, and also testing for the genetic risk factors, which can also be done in low middle income countries, including some of the countries which we are coming from. And based on the symptoms, I'm sure you're all aware, but just to remind each other, commonest symptom of breast cancer, but that doesn't mean all breast lumps are. Some of the breast lumps are really associated with benign disease and not malignant disease. So women can also come with a swelling of all or part of the breast, and also some can have pain. Some can also have nipple retraction. So that means the nipple really turns inwards, and some can have nipple discharge. Majority, they come out with bloody discharge. So bloody discharge is one of the significant signs of breast cancer, although sometimes it might not be. So I also wanted to create an alarm on the fact that not all breast lumps are really associated with cancer. Some are not. But early detection, early screening is significantly important. But you also have to consider prevention measures. So all the risk factors, the mitigation strategy also aligns with the risk factors associated with the breast cancer by itself. So we really have to, as nurses, midwives, and as a strong association, continue educating the public on the importance of limiting alcohol use, cigarette smoking, and also doing a lot of exercise so that we can also control our weight, and also the importance of breastfeeding. So breastfeeding is one of the preventive measures for breast cancer. and also avoiding exposure to radiation, and also looking at doing screening by using mammography, and making sure that we also assess other risk factors like family history, so that women who have got family history of breast cancer, they actually are required and recommended to do regular breast cancer screening, and so that they can be picked early if they're at risk. So from the symptoms of breast cancer, I really wanted to give you this map so that you can see quickly 12 different symptoms which can really women, and also it can affect men as well. So you can have thickening, you can have dimple in the breast. Some can come with a nipple crust. Some, for those with light-colored skin, they can come with redness. And also some can come with a discharge, as said earlier, sometimes breast sores and bumping, and some can also have growing veins. Some can have sunken nipple, and also some can have new shape, new size. And we also have something which is called poodle range, very, very common, significant sign of breast cancer. And finally, the lump, which is commonest, I could say, breast symptom, which affect women as well as men. So I also wanted to give you some photos whereby these are women who were actually diagnosed with breast cancer in Tanzania. So you can see they all come with advanced disease. And we are so unfortunate that the majority of women who are diagnosed in low middle income countries, they come to our facility with stage 3 and stage 4 disease. So actually treatment become really a little bit more complicated, and prognosis becomes really limited. That's why we really have to advocate for early detection so that women can come in with early signs of disease, so that we can be able to manage them early and be able to improve their survival rate. So unfortunately, in 3 of these photos, 2 of these women actually died before even we finalized their management. They were able to start with chemotherapy, but they died 3 months after being diagnosed. So I really wanted to show, which is probably happening also in your countries. So in terms of the key facts, let's look at the burden quickly. So when you look at our data source, which is GlobalCan, approximately 370 deaths occurred in 2022, and we had approximately 2.2 million cases, new cases of breast cancer. It could be more. It really depends on the data management system in the respective country, but otherwise it shows that the breast is really of public health importance. It was second the commonest. It is currently the second commonest, and roughly 50% occur in women, although men are also at risk. And when you look at the country proportionality, approximately 157 countries had patients with breast cancer out of 185. And 1 out of 12 women will be diagnosed with breast cancer in any time of their life. So when you look at the male, I've said it earlier, 0.5 to 1% of the breast cancer cases occur in male. So in terms of treatment is available in most of the African countries, but most likely not accessible in most of the low middle income countries, especially in Africa, especially when you talk about radiotherapy. But however, based on the evidence, treatment is based on the person really stage of the disease, the type of cancer, and where that cancer has really gone far in terms of metastasis. So treatment can be a combination of surgery, radiotherapy, chemotherapy, as well as hormonal therapy, and we also have targeted therapy. So I won't talk much about treatment because we are going to have an oncologist from Malawi who will speak a little bit more on how we are managing breast cancer cases when comprehensive care is concerned. But being a very strong association, I really wanted you to be aware on the current WHO Global Breast Cancer Initiative, which really aims to reduce global breast cancer mortality by 2.5% by 2024. So we really want to downstage the disease. So downstaging of disease, what does it mean? It really aligns with 3 main targets at the global level. So at the global level, we have target which is called 60-60-80, and we really wish to make sure that 60% of the patients are diagnosed in stage 1 and stage 2. And the second 60 is really want to promote timely diagnosis. At least women or men should have a confirmed diagnosis within 60 days. And the last is 80%. We really wish to make sure that more than 80% of the women or men who are diagnosed and confirmed with breast cancer are treated. So currently, majority of patients, they end up dying without even confirmatory diagnosis, even without having a comprehensive treatment. So I really want one of the big take-home message in this webinar is 60, 60, 80. 60, stage 1 and 2, 60, 60 days. Let's make sure that they have confirmatory diagnosis, and let's strive to make sure more than 80% of the patients are treated in your target population. So in terms of program management, health system strengthening, we really have 4 main areas to focus. So one is breast health awareness, making sure community aware on the interventions, especially the primary healthcare facilities, and also making sure we also build capacity of early detection through clinical breast exam is recommended, and also evidence-based screening methodology, although mammography is the evidence and topmost recommended screening, but unfortunately it's not available in most of the low middle income country. And then 3, timely diagnosis, and finally making sure that our clients or patients receive comprehensive treatment. So early detection, what does it mean? Early detection is very, very important because of 4 main factors. 1, we diagnose the disease at an advanced stage, at an early stage, and it is easier to treat. And then 2, they may require less treatment, not very complicated. And then 2, more likely to be very successful in terms of treatment. And also it helps us to improve survival rate of our patients. So when we look at nurses and midwives, so capacity building is very, very, very important. Why is capacity building important? Capacity building is very important because we can be able to pull a number of skilled so that we work together to make sure that we implement a screening and early detection intervention aligning with the 3 global targets I've just mentioned. So making sure we work on the screening component, diagnostic component, treatment component, but we also make sure we track our patient and navigate them quickly to make sure that they undergo the whole continuum of care, they are able to get the treatment which they deserve. So in terms of training, I really wanted you to be aware of the fact that there are different areas of training which are significantly important for nurses, midwives, but also other health professionals. So based on the current experience and also recommendation from WHO, we can also train nurses on clinical breast exam, which is easy. It's just 2 days training, easy to train, and it's competency-based, but also on counseling and also on the component of awareness, so that they can be able to educate the public about breast cancer symptoms, early detection, how to do self-breast exam. We really know self-breast exam can really be defined in so many other communities, because majority of the patients we see, they normally are diagnosed the first symptom by themselves. So people might think self-breast exam, they can ignore an intervention, but it has shown to add value when early detection is concerned. And also we can train nurses and other health professionals on the referral mechanism so that they can understand the referral process from the lower level facility to the highest level facilities, which diagnostic tests need to be done, which treatment methodology are recommended, so that they can be able to counsel and encourage our patients as well. And also when you talk about navigation process, nurses are really a big, important pillar when navigation of patient and survivors is concerned, including providing social as well as economic and legal support as well. So with that note, nurses are really big pillar of support in most of the countries. Sorry, and also we can promote early detection through monthly self-exam, regular clinical exam, and also advising our clients when they can do mammography tests. So additional roles for our gurus, nurses can also educate the public on the importance of early detection, looking at multiple key stakeholders who are really, really important to be engaged. Nurses can educate community at large. Nurses can educate CHW. They can educate and train community leaders, religious, but also they can also educate survivors group and make sure that they are vibrant, available in most of our community, so that they can contribute to factors, how we can be able to prevent, and also the importance of clinical breast exam. Nurses also can play a significant role in assessing and monitoring patients' physical and emotional status. They can also help with keeping the track of laboratory tests which are required, radiological tests which are required, pathological tests which are required, and also tracking the results, making sure that as the second pillar for our global initiative focus on 60 days to have a confirmatory diagnosis, nurses contribute a lot to make sure that timely diagnosis actually is being acquired as early as possible by making sure that they also track results on time. Nurses also can play a significant role in administering medication, specifically chemotherapy or fluids which are required. And nurses can also collaborate very, very well with the multidisciplinary team of clinicians, as well as other, I could say, healthcare providers who are required to make sure that a treatment is offered on time and comprehensively based on the plan. Nurses also are very, very good counselor to patients and their families as well. They can offer emotional, psychological guidance and information to our family members. They can also help the patient to understand their treatment plans and also be a point of contact if they have any concern about any aspect of their care and treatment. Nurses are really very good in this compared to, I would say, doctors. Nurses also can contribute in developing guidelines, because when we develop guidelines, we make sure that nurses are also forefront, regardless of the level of support they offer. They can support, provide their technical expertise, reflection in developing guidelines, tools which are required, including data collection tools, and making sure all the technical documents which are required to make a comprehensive program are developed with their insight as well. So this slide shows some photos which shows different roles nurses can provide in different level of the healthcare system, starting from self-breast exam, clinical breast exam, supporting patient emotionally, and also nurses can also be trained to do breast ultrasonography. They can also support mammography, CB you can see, and also training, the competency-based training. So nurses, when they're capacitated, they can be very, very good facilitators. So in terms of clinical breast exam, I really wanted to remind you on the steps so that we can keep on supporting our programs in the individual countries to make sure that these steps are followed from A to G. And I'm going to share with you this slide so that you can be able to remind yourself. And this is very, very important as a technique. Nurses need to understand how to do CBE effectively, because this is one of the evidence-based screening tools. So if it's not done well, you end up not picking early change of the breast early. So I won't go into step by step, but I wanted you to be aware of this and also remind ourselves. And in terms of how nurses can be able to contribute to improve breast cancer outcome, nurses can do a lot. But I just picked only 5 areas whereby nurses and midwives can add significant value. So nurses and counselor, since they provide evidence-based information, they can contribute a lot to improve awareness, to improve knowledge and community at large. They can also contribute a lot to reduce myths and misconception and fear for diagnosis at the community level. They can also be able to contribute a lot in improving capacity of community members to do self-breast examination and enhance early diagnosis. And secondly, nurses, because they also provide women with evidence-based information and specialized support, as discussed earlier, they can contribute a lot in early diagnosis and making sure that our patients complete the treatment, because they will be encouraged throughout the process, and also making sure that our patients receive palliative care, which is required. Nurses also can support because they understand the context, they understand the services which are required. They can support a lot to make sure that diagnostic tests are done timely, looking at fine needle aspiration cytology when it is required, core needle biopsy when it is required, tissue biopsy when it is required, breast imaging when it is required, mammography when it is required, CT scan when it is required, and all other tests which are required. So nurses can play a significant role to make sure that patients receive all the diagnostic tests which are required, and they can also encourage and support the referral process in the patient navigation system, which can contribute significantly to improve breast health outcome. Nurses also are very good facilitators. They can build capacity of other health professionals and promote peer-to-peer. So by doing this, they can also contribute to increase the number of pooled capacitated healthcare providers who can be able to do screening by using clinical breast exam, and also provide public education and ensuring that at the public level, self-breast examination is done on regular basis. So nurses can also improve breast health outcome by contributing significantly to implement clinical breast exam and enhance referral using single visit approach. So for now, we are promoting the single visit approach whereby clinical breast exam, breast imaging, fine needle aspiration cytology, core needle biopsy is done in the same setting to minimize unnecessary loss to follow-up. So these services can be offered in the facility and also outside the facility. So nurses can contribute significantly to improve breast outcome if they're part and parcel of this process. So looking at the integration, where can we integrate breast cancer education in the primary healthcare setting? There are so many levels, but I've just picked few. So looking at where can we integrate, looking at a service delivery point, looking at our healthcare system structure, regardless of the country, I'm sure all these services are offered. So breast education can be integrated with the maternal health and antenatal care, postnatal care, family planning we can integrate. We can integrate through cervical cancer screening. We can integrate cervical and breast education concurrently in the facility and outreach service, which really contributes a lot to address the double impact of breast and cervical cancer. Breast education also can be offered integratively in the health talk in outpatient clinic, in HIV clinic, in RCH outreach setting, and also in non-communicable disease clinic, also gynae clinic and surgical outpatient setting. So these are really common area of intervention, and really wish to recommend in whichever country you support, making sure that breast education can also be integrated in these service delivery points. We've done it in Tanzania, and it's working very, very well. So in terms of service delivery point, we can focus on facility and outside the facility. So it said area, I'm just going to repeat this, but again, integrating with RCH immunization services within reproductive and child health services, outpatient clinic, it doesn't matter which clinic actually is in the outpatient setting, and also you can integrate and educate on breast cancer in patients. And also in addition to that, when outreach setting is concerned, we are doing multiple outreach services. So looking at the outreach services, we can integrate breast education, RCH immunization, outreach services, family planning, TB, HIV, non-communicable disease. Even you can integrate HIV testing and breast cancer education. And finally, our commonest intervention, which is breast and cervical cancer screening. So with that note, thank you very much for your attention, and I submit. Back to you, moderator.
Thank you very much, Dr. Mary-Rose. Thank you very much. Now, moving forward, I'd like to welcome our second presenter, Dr. Chifundo. And Dr. Chifundo is a consultant surgical oncologist and head of the surgery at Kamuzu Central Hospital in Malawi. Dr. Chifundo is also a member of the Association of Breast Surgery of UK and a member of the Indian Society of Surgical Oncologists in European Society of Surgical Oncologists. And the floor is yours, Dr. Chifundo. Welcome.
Thank you so much. And thank you so much, the moderator and the team, for allowing me to make this presentation. And I think my job has been made a lot more easier by Dr. Mary-Rose. Thank you so much for the good presentation. I was asked to give a talk on the significance of collaboration across various disciplines in healthcare systems to improve breast cancer treatment and patient care. Also covering on the roles of nurses, midwives, doctors, and allied health professionals in a cohesive care model that supports patients at all stages. So most of the stuff that I had to talk about, I think Dr. Mary-Rose has elaborated well. So I'll just go through bits and pieces on just to add up on what probably she didn't mention. But first and foremost is just want to talk about exactly, because we're talking about cancer. So what exactly do we mean by cancer? I think this is a question that most people find it difficult to extrapolate or to explain. So in our bodies, we normally have normal cells, but sometimes we do have abnormal cells. And when these abnormal cells divide uncontrollably, so there are normal cells that the body controls, abnormal cells that the body controls, but you have abnormal cells that the body fails to control. And when these abnormal cells divide uncontrollably, they multiply exponentially and then essentially leading to cancer. So this is the genesis of cancer. In terms of statistics, so I'll draw a little bit on statistics because I want us to understand more on the burden of the cancer as it is now. So there are current different journals that you can read, different papers that you can read, but globally, most of the times we refer to GlobalCan as it mostly focuses on cancers or cancers across the globe. Usually tells about an estimation of cancers in about 135 countries, and that includes the region that we are in. In terms of much of the statistics, I think has already been explained, but I'll just talk a little bit about this. That as you can see in the incidences for both sexes, previously, lung cancer used to be the topmost as far as incidences are concerned, but recent studies have shown that breast cancer has surpassed lung. So as you can see, the incidence of breast cancer is now at 11.7 and that of lung cancer is at 11.4. That tells you the significance of the disease. As far as mortality is concerned, breast cancer falls to number 5 and lung cancer is still the leading cause of mortality. In females, at least 1 in every 4 women would develop, according to the incidences, 1 in 4 of females. And in terms of mortality, it is still the leading cause. That is across the globe. And basically, sometimes when you look at the incidences as well as the mortality, it also has a geographical pattern. But from the graph that I'm showing you, I want you to focus on the last but 1 and last but 2. You realize that those 2 you've got.
Sorry, Dr. Chifundo. Yes, that way we can see.
Yes.
Thank you.
Yes, so you realize that in Eastern Africa and Middle Africa, our incidences are quite low. So the rate of cancer diagnosis is very low. So we seem to have lower burden of cancer, of breast cancer as a whole. But moving forward, look at the mortality. When you look at the mortality, we are on the higher side. So it seems like we're seeing less breast cancer, but those that are dying from breast cancer are so many when you compare to the other region. If you look at the first one, which is Australia and New Zealand, their incidences is at 95.5. That is per 100 individuals. So 95.5 per 100 individuals will have breast cancer. But of that, it's only 12.1 as far as mortality is concerned. In our setting, we have 33, but 17%, 17 per 100,000 would develop, would die from cancer, which is quite significant. And as Dr. Melos showed earlier on, we normally see these patients with all these presentations. And in Malawi, where I come from, at least 76% of our patients from the studies that we have done has shown that patients who come with advanced stage, that's stage 3 and stage 4. But why is this so? Why are we so concerned about breast cancer when our incidences are so low? As I said, mortality is high, but at the same time, when you manage disease at advanced stage, the resources that goes into that is enormous. And it's not just the resources at institutional government level, but as well as at family level. because they have to dig deep to manage these kind of conditions. So we need to strive as a team, we need to strive to diagnose or to find breast cancer in early stages so that we can manage it in those earlier stages. I'll not talk much. I think this was expounded more by Dr. Mary Rose. So we've got modifiable risk and non-modifiable risk. So, but is breast cancer treatable? So this is a question that mostly people would ask you, and the answer is both yes and no. If you find breast cancer in stage 1 and 2, the answer is yes. If you find the cancer in stage 3 and stage 4, especially in stage 4, the answer is no. But in stage 3, it's a yes and no, depending on the level of metastasis. So the answer is yes and no, depending on the stage of breast cancer. There have been several strategies that have been employed and we are employing to reduce breast cancer. And one of the strategies is use of which is called frequent surveillance. So what I want you to understand is that frequent surveillance, which includes self-breast exam, clinical breast exams, screenings, and everything, they will not reduce the risk of developing cancer. So their risk reduction is 0. But what they would do is able to find the cancer in early stage. So our aim is to find at least cancers in stage 1 and 2. So when you do these frequent surveillances, you'll be able to pick up those cancers in those stages, but they will not reduce the risk of one developing from cancer. There are some instances that you have to use chemoprevention. When you use chemoprevention, the drugs that you use, they will reduce the cancer only up to 50%. If, for example, someone has BRCA1 or BRCA2 mutation, as explained earlier on, you do oophorectomy, you remove the ovaries, the risk of breast cancer is not 0, it's also at 50%. Sometimes people would say, okay, I don't want to develop breast cancer, so I'll just take out all my breasts. So you do prophylactic bilateral mastectomies. This really significantly reduces the risk, but it's not 100. So it reduces the risk to 95. So the risk is still there. About 5% of patients will still develop breast cancer, even if you do prophylactic mastectomy. So these are the terms that we normally use when you talk about frequent surveillance. That includes self-breast exam, clinical breast exam, screening mammography, ultrasound, and magnetic resonance imaging. I'll discuss more on these later on. So primarily, I think Dr. Melos talked about this already. So we can advocate for all these to be done. So that includes a self-breast exam and a clinical breast exam. But the pathway mostly is that we can employ the breast self-exam that people can do self-breast exam. When they find something, then they need to see a doctor and do a clinical exam, proper clinical exam. That will entail that one has to do mammography, especially for those that are age 40 and above, but mostly it's about 45 years of age. And then reviewed by radiologists, depending on the findings on mammography, that can end up doing either a biopsy or what is called a fine needle aspiration. Most of the findings will definitely be benign and mostly will be normal. And then they'll still go back to the same routine of breast self-exam. But those that are abnormal are the ones that have been subjected to the test. Another test that have been employed apart from mammography is the use of ultrasound and the use of MRI. Use of ultrasound and MRI, and especially ultrasound, is very convenient as it can be done by the surgeons in the triple assessment setting in the clinics, as well as in the X-ray department. As most of the times we do have ultrasounds available, but not mammography. So most of the times ultrasound will be employed other than the mammography. I like the theme for WHO, which says that no one should face breast cancer alone. And our role all of us here, our role is to make an impact. How do we make an impact? So we have to strive really to make this impact. What we know is that around 2017, the WHO Assembly made a resolution which looked at cancer prevention and control in the context of integrated approach. So what do we mean by this? So we're talking about the integration. So I was asked to talk about the integration of different systems, integration of different resources, human resource and stuff. So role of nurses, role of doctors, role of radiation oncologists, role of palliative care team. This has to be a coordinated approach. This has to be an integrated approach. And as we are saying, no one should face breast cancer alone. We also should not fight breast cancer alone. So what do I mean? I mean that this should not be a fight that one particular individual has to do. So we have to integrate everyone available. Nurses have to play a role. Doctors have to play a role. Palliative care team have to play a role. Radiologists have to play a role. So each and everyone has to have a role to play, as cancer is usually multidisciplinary condition. So everybody has to have a role. But how do we get a role? How do we impact if we don't know the pattern of cancer, essentially breast cancer? So we need to understand the pathway that normally a patient presenting with breast cancer will undergo, right from the outset of the disease up to the almost end of the treatment, as well as death in those cases. So it has been divided into 3 intervals. So you've got patient interval, you've got diagnostic interval, and then you've got treatment interval. As it was earlier said and discussed at length, what you want is that to minimize all these intervals as much as possible. There have been several studies that have been done, and the recent studies on the Concord trial that was done that looked at the delays in starting treatment. That has shown that it has a significant impact on mortality if you delay by more than 60 days. So you want to start the patient on treatment as soon as possible. At the same time, diagnostic-wise, you want to start the patient, to diagnose the disease as early as possible, and it has to be within 60 days. On the patient factors, this includes all the talks that we have been talking about, the surveillance that we have been talking about, the clinical breast exam, screening, all those falls into the patient interval. So the time that one notices the symptom, as well as the time that one undergoes screening, to the time that the diagnostic interval, the diagnosis is intervened. That's a patient interval. So we want, when we talk about integrated services, when you talk about issues of awareness, when you talk about issues of patient management, we want to intervene at this particular point in time. We have patients that present with breast lump that have had the lump for more than 2 years, almost a year or 6 months. We want these patients to present as early as possible when they find anything within the community. That's where our community engagement is quite vital. So we have to intervene at this particular point. And this brings together the role that we all play. Most of the places will find that the leading team is a nursing team. So these nursing team have to be integrated, have to be taught in terms of what to do, how to approach these patients, and when they find these patients, what exactly needs to be done. So issues of training that have already been highlighted earlier on in the earlier presentation have to be taken into consideration. Now we move to the issue of diagnostic. We want it to be done within 60 days. It was already talked about in terms of the duration of intervention. that you want at least 60, 60, 80. So 60 days has to be the interval for diagnosis. We don't want to delay anymore with the diagnosis because the patient presents late already and you don't want to delay them even further. So majority of the patients who undergo what is called triple breast assessment. So triple breast assessment includes a clinical examination and then tissue biopsy as well as radiologic intervention. So radiologic intervention might include mammography, might include MRI, might include ultrasound. And in most centers, we are employing ultrasound, which is legally available. But you can employ anything that is available as far as radiologic is concerned. And then under pathology, then it's either fine needle aspiration, but we normally promote that one does a core needle and not fine needle aspiration. And then depending on the findings, which majority of the cases will be benign. So when the majority of the cases are benign, they go back to the same floor and continue with surveillance. For those that are diagnosed with cancer now, what's the role? It ends up in what is called a multidisciplinary evaluation. So cancer is a multidisciplinary disease that, as I said earlier on, it involves different stakeholders. So all of us have to play a key role. A nurse has to play a key role. Doctors have to play a key role in the diagnosis, in the management of breast cancer. So we want to understand, is this cancer treatable or not? Has it already metastasized or not? If it's cancer that's usually treatable, then you go into the intervention of curative therapy, where it involves surgery, it involves systemic therapy, it involves radiotherapy, and support services that includes palliation. I'll not talk much in terms of the systemic or radiation, but basically what it means is most of the cancers, they will either be given, most all cancers have to be given chemotherapy, be it before the surgery or after surgery, but they have to be given chemotherapy. That's a standard that is being employed. Surgery is a must as far as curative intent is concerned. So if you're aiming for curative intent, you have to employ surgery. And then radiation varies, whether it's the nature of the disease, then can employ the radiation intervention. And as far as I'm concerned, not many centers have radiological therapists. Settings, radiotherapy settings. But surgery and systemic therapy, I think, are mostly available. And systemic therapy could be just chemotherapy, could be hormonotherapy, or could be immunotherapy. And then there are support services that needs to be done. So someone with cancer, even when they're undergoing the curative intent, they normally will suffer a lot. There's a lot that goes on with them, psychological issues. They need that support. So the support from the doctor, support from the nurse within the hospital setting and outside the hospital setting, they need that much needed support. And palliative care team usually will help with this. So be it a curative intent or palliative intent, you need palliative care team to look into all these. As far as disease that has already spread, you also need to look into issues of pain control, supportive care, and the topic that we mostly fear a lot in our setting, especially this part of Africa, is the end of life care. We don't want to talk about these topics, but I think we need to start talking these discussions. We need to start talking about these discussions. They are very vital. We think that when we talk about this, then probably it's a taboo in our setting, but I think they are vital. We prepare our patient, and we need to start talking about those. There have been strategies that have been highlighted to look into how to scale up the surveillance as well as end up with an outcome of early detection for breast cancer. So that our aim is to at least get 60% of level 1, stage 1 and stage 2. So different studies have looked at different models. But the one that we mostly refer to is the early detection and treatment strategies for breast cancer in low and middle income countries, modeling study that was done by Ben Bones. This looked and also gives insights into strategies that can be employed. But how can you employ strategies if you don't know the barriers to early detection? So we have to understand the barriers to early detection. So different studies have been done. Uganda has multiple studies. Ethiopia did a couple of studies, and there have been a number of studies that have come from South Africa. But all these studies, when you look at the findings, they're pretty much similar. So what are the findings from most of these studies? So issues of low knowledge of breast cancer among sub-Saharan women. So this is key. In our intervention, when we are intervening, we need to educate our patients. So as Dr. Mary Rose talked about different stages of intervention, we need to employ these stages. In our setting here in Malawi, we have started talking about it in antenatal clinic. We have started talking about it in cervical cancer awareness clinics. And we are still in the process of integrating into the HIV clinics. But what has happened is that we have seen that there is indeed power when you integrate most of these already set up structures, and then you upscale them by introducing some of these messages, especially involving the breast cancer knowledge. There's always lack of awareness of early detection, treatment, poor perception of breast cancer, and all these social cultural factors that have been put in place and that have been cited as a barrier to early detection. So we need to break these stigmas, we need to break these barriers, and it's a duty of each and everyone to break these barriers. There are other factors like economic factors, which cannot be we can't do much about them, but we have to strive to find better ways of managing them. There are issues to do with systems, our systems. How do we collaborate our system? And the systems on their own have had negative impact on our patients. We've seen from our hospital that patients, from the studies that have been done, these are the findings. They talked about misdiagnosis of breast cancer. We have also seen this in our clinic, that patient will potentially go to a clinician, probably in a low setting, in the primary healthcare setting. They will go there, and most of the times they'll be diagnosed as infection, being given antibiotics. When the patient is presenting to us 6 months down the line or a year down the line with the cancer, it's already advanced. But this patient presented quite early in the course of disease. So this also needs to be highlighted. So the misdiagnosis, how do we handle this misdiagnosis? I think the most important thing is about training, it's about education. So the education that we have to give is not only to the patients that we have, but the staffing that we have, the clinicians, the nurses, whosoever is involved, they need to know how to make a diagnosis of breast cancer, how to understand how to diagnose it, the clinical features of patients presenting with breast cancer. In other centers, if that's not the case, then they have to refer to a secondary level where they'll be able to diagnose it as early as possible. There'll be issues of long distances that have been highlighted from the studies, high cost of diagnostic services, which is really a problem in most centers, and the long waiting time to diagnosis. So in our settings, we normally have less numbers of pathologists. And because of this, the waiting period for the diagnosis is prolonged, but we have to strive to find ways of reducing this. And most of the times, the diagnostic in terms of long waiting period involves issues of transporting the sample from a primary hospital, primary center to a pathology lab, and from pathology lab to the primary center. That also increases the delay. So we need to cut on all the possible ways that we can to minimize that, and the screening programs. But whose role is it, as far as if we want to target this to reduce the late presentation, whose role is it, and who are the players? So the answer to all these questions is all of us are the roles, all of us have a role, and all of us are the players. There is WHO, I think, looked at some of the initiatives that needs to undergo for us to intervene as far as representation is concerned. So they integrated what is called Breast Health Global Initiative. They what they did is to call upon experts from across the globe in all fields to have a meeting to look at the barriers and ways of how to manage those barriers. And when they looked at those, they tried to do what is called a resource stratification for the minimal resources that we have. How do we divide the resources so that they are put to the best of care? So the different strategies that they looked into. I'll go back to the same slide that I talked about. So different strategies that have been put to in terms of implementation. And how do we implement? We cannot implement at one particular point in level. So we want to implement at patient interval, at diagnostic interval, as well as a treatment interval. How do we do that? So the most important, there are 4 steps that we have to do to implement. So the first important step is stakeholder identification. I'm happy here that we do have ECSA here, ECSACONM. We do have Dr. Menlos from Japaico. These are our stakeholders. We need to identify our stakeholders very well and work and collaborate with them. When we work and collaborate as a team, then we will achieve something bigger. So identification of all our stakeholders, and the biggest stakeholder is the Ministry of Health in our government. So we need to engage the Ministry of Health in our government so that they should engage in all these awareness messages that we have to employ as far as this is concerned. And then what else do we need to do? It's to do situation analysis. So how do we do that? There are different ways of how we can do that. So think about workforce analysis. You have to know that your staffing levels, if we employ everything on breast cancer, the others will suffer as well. So these people are doing a lot. So we have to think about how do we intervene in terms of analyzing our workforce. How do we make sure that we, even if we introduce these other services will not suffer? The geography, we also need to understand that some areas are hard to reach, some areas are easy to reach. We have to understand that, as well as healthcare resource mapping, understand where to put what and where not to put anything, as well as what is called patient pathway system that we talked about. So you need to understand this. By understanding this, then you know that your patient will move from point A to point B to point C, and that will help you to mobilize the resources and to put the resources to good use. Then the next step is what is called health system framework and cancer control planning. So by this, what you need now to use is the data on regional disease patterns. So you go back to your data. If you have a cancer registry, you go back to your cancer registry and look at your cancer registry. Where are most patients coming from, for example? There's no point in, for example, if you're in Zambia, Ndola is having more patients, but Chipata is having very few patients from cancer. You have to think about it. Why is Ndola sending so many patients with breast cancer to Lusaka? The reason might be that probably the nurses and doctors in Ndola are doing a good job, but it might as well be that the burden of breast cancer is higher in that region. So by doing this, it helps you because if you're mobilizing resources, if you're mobilizing staffing, you know where to put the staff, where to put the resources more, so that it benefits a lot more people. And then the implementation of everything, it has to be a stepwise. Do not just zoom in on one particular point and push in everything at one particular point. It has to be a stepwise, analyze, stepwise, analyze, stepwise, analyze. In that way, then you will improve the services. How do you improve or how do you implement in a phased way? The important aspect is to do a systematic triage of the program for management of palpable disease. So first and foremost, the mistake that we have done before, and I think we try to avoid, is that for a patient who presents with a palpable disease, palpable mass, what is the pathway? we need to have a proper pathway of these patients that has been done. So when we have our colleagues and nurses and doctors that are doing surveillance, that are doing clinical breast exam, that we have been taught to do clinical breast exam, when they find a mass, what is the pathway? What do they need to do? So this is very important because often anytime they'll find a mass, they'll just say, okay, there's a mass, I'll send you to the central hospital. But how will the patient get from this institution to the next level? And within the next level, how are they managing that? That's also very, very important. And that's how the system should be collaborated. So there should be collaboration at different stages of healthcare plan. Now, when you do that, it means at the receiving end also there has to be a system that when if a patient comes with a palpable mass, this is what we have done, a laid out plan. This is what we're going to do A, B, C, D. And that is very important. And then what you do is to do resource mobilization and patient care pathway. That also includes and gives me to the point of patient navigators that was already talked about. We also need to involve, I think, patient navigators. They play a critical role because oftentimes patients, when they come, their pathway is not as straightforward when they come. We look at this, when you talk about this complex table that's showing in front of you, patient has to undergo all that. It's not easy for someone who is already stressed with the burden of the disease to undergo all this alone. When you have navigators, they take them through all this and it helps. So you can have nurse navigators. A nurse knows the system. They'll be able to take the patient and they'll take the burden of the patient, they'll take the burden of the system on their shoulders, and they'll be the shoulder of the patient. The patient can give their grievances to this navigator and they will interact more. And that also helps to reduce the stress that comes with the disease on the patient. And then next in line, you have to scale up the targeted education intervention. At this point in time, if your primary disease center where you'll be treating all these cancers is not fully supported, there's no point in supporting targeted education and intervention. There's no point in going to the community and doing awareness. Because if you do that, you are creating unnecessary burden to the receiving end. At the same time, you are creating a state of panic for those that have been found with the condition, and yet they cannot access the service at the referral center. So it has to be a stepwise, build the capacity first, and then mobilize the resources, and then you scale up the targeted education. When you scale up the targeted education, then you start upgrade the image and image-based diagnostic systems. By that way, then you have a system that is robust and a system that is functional. Our aim is to do an early diagnosis, and as I said, it involves different stakeholders. So everybody has a role. So we have to think about the target population, and in our setting, most of the times are the symptomatic women, and then we have to do
Sorry,
a
Dr.
diagnostic tool.
Chifundo, you only have 2 minutes to finalize. Only
Yeah,
2 minutes remain. Okay.
I only have 2 slides remaining.
Okay.
Yes. So you have to improve on diagnostic tools and program approaches. So when you expedite all these pathways, then you end up with patients that are coming with early diagnosis. And these have to be a phased approach. Do not scale up to any level if any other level have not been properly managed. You reach the organized screening, but to reach the organized screening, then it's resource intense and only have to be done in settings that have got better resources. And as I said, I think this slide has already been highlighted before, and those are my references. Thank you so much.
Thank you, Dr. Chifundo, and thank you everyone for holding back. We'll now allow 2 questions from the participants before we can close. You can as well put it into the chat, but you can raise your hand and you'll be allowed to unmute and ask if you have any question. Okay, thank you very much. I would like to welcome Lemmy to close the session for today, and also to welcome the Vice President if available to speak. Thank you.
Thank you so much, team. But special thank to Dr. Mary Rose and Dr. Chifundo for a very comprehensive presentations. Even for a lay person like me, now I've understood the science and all the details regarding the breast cancer. So we appreciate so much for your time, and thank you all participants who will share the presentation. And if you have any question, please, you can send it to Nina, and Nina will reach out to our technical experts for them to respond to your question. And for now, I would like to welcome our Vice President, Madam Evelyn. Evelyn, you are welcome to close the webinar. Madam Evelyn, you are on mute. Yeah, I think she's on the way. She's traveling. Maybe she's at the site where she cannot unmute or talk. So I would like to end the webinar. Thank you all for the participation, and have a good afternoon all. Bye for now.
Thank you, everyone.
Thank you.